Next in this review, we're going to cover medical emergencies, and these are wide spectrum. Again, your training in OEC qualifies you to handle the basics of most of these emergencies, so I'm just going to cover the parts of the protocols that expand your practice a bit, or at least give you a basis for your practice. And again, you're responsible for all the protocols, but most of it you would have been doing on your own, even without the protocols there. So, chest pain, and this is chest pain of suspected cardiac origin, non-traumatic chest pain. We're talking about patients older than 35. We request an ALS EMS response. That's sort of the first thing. We need to get them a 12-lead EKG, something we can't do, so we need to get the paramedics available to us immediately to do that, because that triggers a whole lot of other downstream things within the regional medical care system. They may need additional medications as well. If the patient has not taken aspirin, they don't have any bleeding history or ulcer disease history, and they're not on any blood thinners, you can give them 4 baby aspirin, the 81 milligram aspirin, low strength aspirin, for a total of 324 milligrams of aspirin. They chew and swallow those. You can give them a little bit of water because they're kind of grainy when you chew them up. And if the patient has their own nitroglycerin and they've not taken any medication for erectile dysfunction in the last 24 hours, and the medications can be used for things other than erectile dysfunction, so you have to ask them specifically about the medications, or ask them if they take any medications that are used primarily for either pulmonary hypertension or erectile dysfunction in the last 24 hours. And if they haven't, then talk to online medical control 973-8000 at the Eastern Maine Emergency Department, or any physician who happens to be on scene who's a medical control physician. So Dr. Jones, myself, or one of the EMMC physicians who's providing on the Hill medical control about assisting the patient with their own nitroglycerin. If we've got a patient who's in shock and it's not traumatic shock, give them oxygen. Airway management is needed. Now, there's still this tendency to want to put them in a head down position. There's evidence coming out now really saying that the shock position, the elevated legs, does not improve outcome and may worsen outcome. And the reason it would worsen outcome is as soon as you tilt somebody with their head down, all of their abdominal contents rest right against their diaphragm, so they have trouble breathing, and that's going to worsen any shock situation. So use your judgment, but generally speaking, if you're going to transport them, you can transport them head down. I wouldn't go out of my way to particularly elevate the legs, and if they're in shock, you're going to need ALS EMS. And remember, shock is not just a low blood pressure. Compensated shock, their heart rate may be up a little bit relative to where it should be. They may be agitated, they may be a little sweaty, their skin may be cool, it may be pale. A lot of things that are hard to sort out on the hill. So if you have concerns, get them off the hill into the aid room, start assessing them as soon as you can. If someone is having an allergic reaction and you think it's severe, it's anaphylaxis, then they need epinephrine. So anaphylaxis is typically a skin finding, skin redness, skin urticaria or hives or wheals, typically itchiness, associated with problems with the airway swelling, so difficulty breathing, bronchospasm or wheezing, high heart rate or shock, low blood pressure, diaphoresis and sweating, signs of shock, and any major GI symptoms, so sudden severe diarrhea or vomiting. So skin findings plus any of those, or a known exposure to something that causes anaphylaxis, and any symptoms that compromise the airway, breathing, or circulation. If they have their own epi auto-injector, you can help the patient self-administer it. If they can't self-administer it, but they can hold it out to you, you may perform epi auto-injection. You may administer it to the patient if it's their own epi auto-injector. If it's not, or they've already used their own, call online medical control 973-8000 and get authorization to use the patrol supplied epinephrine auto-injector. they're going to need an ALS EMS response. Anybody who gets epinephrine needs to be observed for at least 3 hours, and so they need to be transported to a hospital where they can be appropriately observed. If you find a patient who's comatose, put oxygen on them. If they need more aggressive airway intervention, bag valve mask ventilation, placing a king, an oral or nasal airway, do that. If there's a glucometer available, check their blood sugar. If it's less than 80 and the patient still alert enough that they can take oral glucose, you can give them a tube of oral glucose or at least 5 lifesavers or similar high sugar candies. You're going to request ALS EMS to assess and transport the patient. If they're completely unresponsive, don't give them anything. If you've got a known diabetic who's having a diabetic emergency, put them on oxygen. If they need airway management, provide airway management. If they're conscious and they're able to swallow, give them a tube of oral glucose or at least 5 lifesavers. That just tides them over to wake them up. They need to eat real food after that. A slice of pizza, a sandwich, something with protein and fat. If a glucometer is available, check their blood sugar and call for ALS EMS. They may end up refusing medical care. If they do, after you've corrected them and after they've eaten something that's probably okay, talk to medical control. Call online medical control about that. If you've got a patient who's having a seizure, oxygen, airway management is needed. Protect them from injury. If you're transporting them on the hill, you don't immobilize and strap them down because the seizure activity itself can cause fractures. They can break their own bones fighting against the restraints, and so you just need to transport them in a way that they're not going to injure themselves. Now remember, most seizures will terminate within 5 minutes. It is incredibly unlikely, unless we happen to be training right there, that we're going to have a toboggan right by the patient in 5 minutes. So chances are they will have stopped seizing by the time you get them onto the toboggan. However, they could start seizing again, so you just have to monitor them during the transport. And if you got a glucometer, check their blood sugar, treat them accordingly. If you think somebody has a stroke, and the big symptoms of the stroke are going to be facial droop, or difficulty speaking, or arm or leg weakness on one side of the body, what we call lateralizing findings, put them on some oxygen, low flow, nasal cannula is fine. Airway management if needed, if they're unresponsive. Check a blood sugar. If the blood sugar is low and they're still awake and alert and can take oral medication, give them the oral glucose or the frosting or 5 lifesavers, because low blood sugar can look exactly like a stroke, and so try to treat that. If everything resolves, that answers your question. If it doesn't, then they've had a stroke and they need further evaluation. You call for ALS EMS. Hypothermia, it's standard treatment per OEC, so core rewarming, be very gentle in moving the patient so as to not trigger a regular heartbeat, and get them into a warm environment. Hyperthermia we are less likely to see during the winter, although it could happen to one of the employees in the mountain if they were working in some of the few very hot environments we have. But in the summer, if we're supporting any events, use standard treatment as you learned in OEC. And that's basically get them cool as fast as you can, and then don't overcool them. Okay, so that ends the medical emergencies. Go ahead and you can finish or take the knowledge assessment associated with that material and those protocols.